Hi everyone! Here we are almost finishing this third day of the International Aesthetic Masters 2017 and I really hope you're getting the most out of each lecture. Now let me present a very important and special friend of mine and great colleague, Dr. Rui Pereira da Costa. I am sure you know him not because of aesthetic dentistry but for endodontics, the area he is deeply involved for many years. Of course, you also know him as he is my great partner in this project. Rui is one of the most visionary colleagues that I've encountered and someone with whom I've shared so many great clinical, educational and personal moments with. Besides his passion for dentistry, for new internet and educational features, he is for me one of the greatest endodontists that I've had the chance of working with and someone that is always keen to enhance his knowledge, expertise and clinical ability. Rui graduated from the University of Oporto in 1995 and then got a Master of Science in Endodontics from the WIC University in Barcelona in 2004. Presently, Rui is Assistant Professor of the Master in Endodontics Postgraduation Program at the WIC Barcelona since 2005 and is also Assistant Professor in the Postgraduation Program in Endodontics of the University of Lisbon, the Dentistry College. He is nowadays a Fellow of the International College of Dentists, has an exclusive practice in endodontics and has his own educational center in endodontics as well for more than 10 years. Dr. Rui Pereira da Costa has been a great visionary and has first launched a World Online Congress in 2015, beginning with endodontics and in the end of that same year together with me in aesthetic dentistry. We are always pushing each other to have new ideas, to launch new projects, to perform better clinically and to enhance the world's dentistry through knowledge. And Rui has been outstanding, changing the face of worldwide dentistry. Rui will present the subject, Will Minimally Invasive Endodontics Forever Change Aesthetic Dentistry? And connect, in fact, his expertise in endodontics with those that practice aesthetic dentistry. I am sure you will love his presentation. See you soon.
Hi, my name is Rui Pereira da Costa and it is a great pleasure and an honor to be here once again to share with you my passion for endodontics. So, first of all, I would like to thank João kind words. It is in fact an honor for me to be co-organizing this huge event and to be able to share dentistry and the best aesthetic dentistry in particular has to offer to the world. At this moment we have a huge amount of participants, more than 11,000, and I believe that by the end of the week's Congress we'll have much more. We have an immense number of countries participating, so this is at the same time overwhelming and humbling because it all started 2 years ago with a very naive idea, should I say, that I had to share to the world and to bring the best we have clinically and scientifically, especially to those countries and to those colleagues that work in distant places and that have more difficulty because of geographical or political or financial boundaries that in a way impedes them to attend big congresses and to see the top speakers in the world. So I had the luck to have many friends that joined this idea in the very first edition, many of them not knowing even what was exactly the idea behind the concept, but at the end it really was a game changer in the learning paradigm. So I think that nowadays many colleagues really say that this international masters, the endo masters and the aesthetic masters have in some way changed the way we learn dentistry and the way we share dentistry to the world in a manner that was unbelievable or was never thought before. So it's really rewarding to see how far we got and the response, the massive response we have from many colleagues and also from you. So it is a great pleasure for me to be here, as I said once again, to share a little bit of what endodontics has to do with aesthetic dentistry. Well, first of all, let me present myself. Probably some of you already know me from the previous congresses, but those who don't, let me say that I am a Portuguese endodontist. I work in Lisbon. I'm connected to International University of Catalonia in Barcelona and also the University of Lisbon. In both places, I'm connected to the post-graduation programs of endodontics. And I live in Portugal, this beautiful country, and you're watching some very nice footage from Portugal, and I would like to take the advantage of being here and being in front of such a massive audience to invite you to come to Portugal, to visit us, and to really discover the beauties that we have in our country. So Portuguese, as you know, were tied to discovering the world 500 years ago, and it kind of resembles what we're more or less doing in this event, as we are reaching the world and we are bringing knowledge, and we are bringing and sharing ideas with you and with all the colleagues from around the world. So endodontics is no exception, and it really has a very big place in this Congress, even though I am the only one that will talk about endodontics and aesthetic dentistry from beginning to end of the presentation. I am sure that if you are following the lectures of this week's Congress, you probably already heard a few lecturers talking about endodontics related to their particular treatments. But we always try to have some topics that are related to aesthetic dentistry, even though they are not considered the core of aesthetic dentistry. When you think about aesthetic dentistry, you normally think about composites, you think about veneers, you think about prosthodontics in general, but we have to believe and we have to accept that aesthetic dentistry is a very transversal, a very huge area of performance in the dental field. So it connects with lots of specialties, and you have already had the opportunity, I hope, to watch the beautiful lecture from Jean-Pierre Attal that was concerning the specialty of orthodontics, and you also will have a presentation from José Nart that will present about periodontics. So as you see, these specialties, even though they seem at the beginning a little bit far away from aesthetic dentistry, they are intimately connected, because aesthetic dentistry really is supported by several pillars to bring the best treatment to our patients, and endodontics is no exception. So I said to myself that I would try to bring a topic that is at the same time very connected to aesthetic dentistry and, if possible, modern and a little bit controversial and trendy. So that's why I chose to talk about minimally invasive endodontics. So if you follow endodontics in general, if you go to forums on social media or in the web, or if you read articles on the literature, you have already realized that in the recent times, minimally invasive endodontics has been a very spoken topic. And we are talking about performing endodontics with the less possible destruction of the crown. We all know that when we do an endodontic treatment, we have to do an opening on the surface of the crown, and that leads inevitably to some destruction of the crown and a kind of a diminish of the resistance of the structure. That is undoubtful. So we have to understand how much is the impact on that destruction and the resistance of our teeth. And that's why that following a philosophy and following the modern trend of minimally invasive that you see everywhere, even in aesthetic dentistry, you probably have already heard several speakers speak about minimally invasive dentistry. So very small preparations, very conservative and everything. So why shouldn't endodontics follow the same path? So that's what we're talking about, and try to kind of analyze and make a reflection on either it is a good path, what are the advantages, if are there any disadvantages, is it possible, does it have an impact, and for that reason I think that you have beyond you more or less 1 hour of a presentation. Then I think it's going to be interesting and to kind of set the bar on where we are at this moment relating to this topic of minimally invasive endodontics. So let's start by explaining, first of all, what is the endodontic access. And we know that the endodontic access is the opening in the dental crown that, of course, permits the localization, the cleaning, the shaping, the disinfection, and the three-dimensional obturation of the entire root canal system. Okay? Everyone who performs endodontics, and even those who don't perform endodontics, knows this. So, if you ever perform an endodontic treatment, you probably have already felt what I'm going to explain next. Is that when you start, or when you're preparing to initiate your endodontic treatment, you have your diagnosis done, you have your initial x-rays on your side, you have the rubber dam in place, and you are going to enter that tooth and you are going to perform a beautiful endodontic treatment. So at this moment, you are in the endodontics mode mindset. You are really concerned to access as fast as you can and to locate the canals and to see if all the canals that you expect to encounter in that tooth are located, and then you go, and at that point, more or less, you probably feel that your adrenaline drops a little bit. You become a little bit more relaxed, and then you go with your treatment. So if you relate with this, I think that you probably feel what I'm saying, that at least a few times you have already felt this sensation, this adrenaline before, and a kind of a relaxing state after you enter the pulp chamber and you find all the canals. But the endodontics mode mindset is something that we should not enter right away, because before entering in this endodontic, before turning this switch of endodontics, we should always check the restorability of the tooth prior to the root canal treatment. And this is really, really important. Of course, existing restorations, caries, and unsupported enamel and dentin should be removed, and the remaining tooth structure should be examined under magnification. Or at least it should be examined under magnification whenever possible. Magnification is a huge advantage that we nowadays have in our treatments in all specialties, and endodontics is of course no exception. I think it's even more important in endodontics than in other specialties. So we're going to talk a little bit of magnification afterwards. So what I'm trying to say is that before entering the endodontics mode, you have to check the restorability. And why? Because the literature has already proved that if you don't do a complete removal of your restorations, you have less than 60% chance to detect caries, fractures, and marginal breakdown. Yes, you do in fact can leave some caries, you can leave some cracks, some small fractures that go undetected, and you just started endodontic treatment without correcting or without assessing and evaluating if those specific problems are going to have an impact, of course a negative impact, on your treatment, on the future, on the structure, on the resistance of that tooth. So it is very important to kind of give a step back, gain a little bit of perspective, and don't jump towards the endodontic treatment right away. Okay, so when we're doing this assessment, we should search for the presence of cracks, also evaluate the height and the thickness of the remaining dentinal walls for ferrule effect, which is, as you know, very, very important for the rehabilitation of that tooth after the endodontic treatment, and also the relationship of the remaining coronal margins relative to the osseous crest. This is also very important because if we kind of invade the biological width, it's going to have an impact on the restoration of our tooth, and maybe we have to do some prior procedures, for example, like an orthodontic extrusion or a surgical crown lengthening, in order to have or to gain that minimal height that will then allow us to restore correctly that tooth. So all these evaluations, all these assessments should be done before we switch on the endodontics mode mindset. Okay, so after we've done that, we are going to start our endodontic access cavity. And the endodontic access cavity is made of several steps. I'm trying to at this point to divide them in small steps so it's easier to understand, and so it's more predictable if we follow kind of a guide map to take us from beginning to end with the maximum correction and with the maximum quality that will allow us the best procedures afterwards. Endodontic cavity is a very, very important phase of all the entire endodontic treatment because it has a direct impact on the success or failure of the treatment, as we'll see afterwards. Okay, so first of all, the first thing we have to do is, of course, the penetration through the occlusal surface. And well, you probably now are thinking, okay, so we're talking about burrs, we're talking about maybe ultrasonic tips, but no. The most important tools for this specific step are not burrs. They are the hand-eye coordination, the well-tuned imaging skills. And why? Because we must always remember that when we initiate an endodontic treatment, we are doing so based most of the times in two-dimensional images, which are our x-rays. So we are kind of transporting this bidimensional image into a three-dimensional structure, and this is really very difficult to do. So our brain is not very used to do this exercise, but I really would like to highlight the importance of having this very well-tuned imaging skills so that we can kind of imagine the three-dimensional structure of the tooth when we are entering the pulp chamber, when we are approaching the pulp chamber. Otherwise, if we stick to that very flat image, we'll lose a lot of the imaging of the structure, and some of the dimensions are lost, and we can go on the very wrong way and end up with a mishap or an accident, or at least some misdirection of our burr that maybe we can correct afterwards, but of course it will make the endodontic access cavity wrong right from the beginning. So, and finally, of course, we have to have lots of patience, thought, and determination. It is very important to be assertive when we're doing these procedures, but we have to be very knowledge of what we're doing, and we have to have these important tools very well and fine-tuned in order to go forward without any mistakes and without any mishaps. So the next step is finding the pulp chamber. Okay, so we're penetrating and then we at some point find the pulp chamber. After we find the pulp chamber, this is very important that we have a very good direction of our burr, and we should always remember that the burr should be directed towards the area of the pulp chamber where you have probably the higher volume, the biggest volume of pulp. So, for example, if you're trying to access an upper molar, you should kind of direct your burr slightly towards the palatal root, because in that specific area of the pulp chamber is where you'll probably find the biggest volume of pulp. So it's the place, the spot where you'll probably have less risk of deviating, and you'll have the highest chance of finding right away the pulp chamber. So after finding the pulp chamber, you have to unroof the dentin that covers the pulp chamber. So by removing the roof laterally or peripherically, eliminating all the roof until you get very smooth walls right in direction to occlusion and with a small, slight divergence occlusally. So this should be done with specific burrs. Some burrs that I would like to recommend are those that have a non-cutting tip, like the EndoZ or like the Diamendo, which are burrs that, by this special feature that they don't cut in their tip, they are much less aggressive and much less dangerous if we, by any chance or if by accident, we touch once or twice the floor of the pulp chamber. So in this case, I think that really it is important to believe that using these specific burrs is a good way of avoiding mishaps. So these burrs, as you can see, they are cylindrical. They have a small divergence towards occlusal. So they are specially indicated to create smooth walls with a slight divergence towards the occlusal. Probably you listened or you even learned in the university that round burrs could be a good option in this specific step. By kind of brushing from apical to occlusal, that would be a way of removing all the most peripheral parts of the roof that still exist in that area, and the pulp horns and everything. But actually, the use of the round burrs is not very recommended because they cause indiscriminate gouging of the walls, as I'll show later on an animation that kind of explains exactly what happens. So if we want to have very smooth and straight walls, those burrs, those round burrs, are not very recommended, and it's much easier to achieve this with burrs like the EndoZ or the Diamendo with non-cutting tip for higher security. So what is the final form or the final shape that our endodontic access cavity will have? We know that classically we learned that they can go from triangular to oval or quadrilateral. More or less, those are the classic shapes or the final contours that we achieve after our endodontic treatment. And this is correct. Nonetheless, we should always consider that once the pulp chamber has been found, the cavity should be tailor-made. Specifically, each tooth has its own individuality. So we should access and we should correct the endodontic access cavity, making sure that the final shape or the final contour occlusally is exactly a projection of the roof of the pulp chamber on the occlusal surface. A little bit enlarged because we're making slightly divergent walls, but nonetheless it should be a complete projection of the roof. So if of course you have a tooth that has a more calcified or a more constricted pulp chamber, probably the shape that I showed in the previous slide will not be as enlarged. Maybe you'll have a triangular shape but a smaller triangle. Maybe you'll have an oval but a smaller oval. So it is important to not get stuck to this idea that they should all follow a specific and a preconceived form, that and we should be aware that slight changes can be made and should be made according to the tooth that we are accessing. Okay, so next stage is the discovery and identification of all canals present. So this is of course an important part of the treatment. It's the one that I explained before, that many of the dentists think right away when they think of endodontic treatment. They don't think very much about the endodontic access cavity per se. What they think is trying to get as fast as can to the pulp chamber to get to this phase, to this discovery and identification of all canals present. Well, this specific step brings us to a huge topic that we should all be very aware of, which is the root canal anatomy. So a thorough knowledge of the number, incidence, location and variability of the canal system of each tooth and root is mandatory. So we should know our anatomy. Endodontics is most of all root canal anatomy. That's what makes it so fascinating, so challenging, and at the same time a little bit more difficult, because if we didn't have the complexity that we have, endodontics would be probably much more easier. So the first thing that we should always remember is that if our brain doesn't know what it's there, the eyes will never see it. Okay, so we have to know, we have to have a thorough knowledge of the root canal anatomy, of the anatomies of the canals, the possible variations that we may encounter in each tooth, in order to, when we initiate a root canal treatment, be aware that that is a possibility, and it is something that we should always try to identify. And if we know, if our brain knows it, you'll probably start finding much more ambi-2s, middle mesial canals, premolars with 3 canals. Those situations happens. They are not the most frequent of cases, of course, but they do exist. So we have to be very aware of that situation. One thing that can happen, that can help very, very much in this specific step, is of course magnification. And according and related to magnification, I would like to share with you an article that I think it's really very interesting. It has a few years already, but I think it shows us the power of magnification when we're trying to identify and locate canals. So this specific article was made to assess the effect of magnification on the location of the ambi-2 canal in upper first molars. So what they did in this study was to divide the sample in 3 groups, and they assessed, or they evaluated the percentage of canals encountered, or second canals encountered on the mesiobuccal root without any magnification, with loupes and with microscope. So without any magnification, they found approximately 17% of cases with 2 canals in a mesiobuccal root. Not very big number, but nonetheless they found some. When they use loupes, you can see that they increased a huge amount of percentage, and they found 2 canals in almost 63% of the cases. And with the microscope, you're probably thinking that we're getting close to 90% or something, but no, it's a little bit less. It's 71.1%. Of course, there are other studies with a higher percentage than this one specifically, and we all know that microscope is a very important tool in endodontics nowadays. But I would like to highlight in this study that the biggest jump the biggest improvement was when we passed from nothing to something. So it is important for you to realize that using magnification, even if it's not a microscope, many times people think that, well, I'm doing endodontic treatments, I'm a general practitioner, but I cannot afford a microscope. Or if I want to do high-level endodontics, I should have a microscope. And this is not 100% true. You can do marvelous endodontic treatments without having the microscope. The microscope is a wonderful and a mandatory tool if you are a specialist and if you deal with very difficult anatomies, if you deal with other challenges that would be almost impossible to realize, would be probably impossible to do without the microscope. But that's not the case that we're talking here. We're talking about the location and identification of root canals. So in this situation, I think that the loops can be a very big improvement in your practice. So the final step of our endodontic access cavity that many times is not considered as a part of the endodontic access cavity steps is the achievement of a straight line access to the apical third of the root canal. And this is a very important stage of our entire procedure, because acquiring the straight line access is one of the biggest steps to avoid mishaps and procedural errors during instrumentation. And let's talk a little bit about that. So first of all, let me say what's this straight line access. So the straight line access is a preparation that provides a straight or outwardly flared unimpeded path from the occlusal surface to the apex, and this will allow the file to reach the apex with minimal deflection. So without minimal bending inside the root canal made by or forced by the natural anatomy of the root. So if we think about a tooth and if we make it transparent, we'll see that the root anatomy or the root canal anatomy is complex. And if we imagine our file going through the occlusal surface and entering, for example, one of the mesial canals, we would imagine something like this. So you see that this 10K file is a little bit forced due to the anatomy of this tooth, and this anatomy makes that when the file enters, it is deflected at its tip by the force that is exerted by the dentin. So this is kind of it's physics nonetheless. So the file tip exerts back an equal and opposite reaction upon the dentin as an attempt to straighten back to its original dimension. So of course this happens as much as more rigid is the file. So if the dentin exerts a greater force than the file bends, like we see here in this K file, in this 10K file, but this changes if the file size increases. Even if the file is made of nickel titanium, that, as we all know, is much more flexible than stainless steel, even though from a certain point the file becomes rigid enough to provoke kind of greater force than the dentin. So eventually the file will cut the dentin rather than bend. And it will cut the dentin in two very particular spots. So in the apical portion of the root canal on the outwards direction of the curvature, and on the medial, the medium portion of the root canal inwards. So in an inward direction towards the center of the tooth. So if this cut is slight, maybe it doesn't impact much in the final result of the treatment. But if this cutting of the dentin becomes a little bit more aggressive, then you will have in the apical portion a deviation of the root canal, the formation of a ledge, or on the worst case scenario, you would have even a perforation. And the perforation on medium part of the root canal is not that rare to encounter. What we have here is what is called in the literature a strip perforation, which is an excessive cutting of the dentin on the inner part of the canal, on the median part of the root, that leads to a perforation that is called, as I said, a strip perforation. So when we have our initial X-ray like this one, we should be attentive to the existence of a constriction in the pulp chamber. And this constriction can kind of make the file go on a direction that we don't want it to follow. So if we do our endodontic access cavity in this tooth and we are trying to scout the canals, we're trying to do some kind of negotiation of the canals at this stage, we would probably encounter something like we see in the photograph. So what if we look at that photograph specifically, we kind of see that the file seems to enter the canal in a straight line access because, well, the metal of the file is right on the mesial side, touching the mesial wall. But that's in fact not true, because if you look closely, you'll see that in the corner of the photograph, you see my finger holding the file cable. So if I let go of the file, this is what happens. And this happens because, of course, as you see in the illustration on the left side of the slide, you have the anatomy of the root canal forcing the file to bend and forcing the file to a position that makes it more stressful and more difficult to follow the path and more prone to errors and to mishaps. So what should we do? Of course, we should eliminate this yellow area, which we call the dentinal triangle. There are several names in the literature, but this should be corrected so that we can kind of relocate the canal entrance on a more mesial position, and that way we'll have a more straight line access to the apical part of the root canal. So exactly like we see in this X-ray, where we see the files entering on a much less forceful way until the apical portion of the root canal. This doesn't mean that the file won't have apical curvatures. We all know that the apical portion of the root canal is the most complex, where you'll find the most complex anatomy. But it's completely different to have the file being forced only on that specific part, where the file is inclusive more narrow. So if it is more narrow, it is more flexible, it is less prone to deviations than on the coronal part of the root canal, on the coronal third of the root, where you'll have the highest mass of metal trying to return to the original position and destroying much more dentin than we would like. So this is really very, very important, and these are examples that I found in X-rays of patients that arrived at my practice, that we see fractured instruments on the root canals. And even though I don't know exactly what happened, I can imagine that probably the access cavity and specifically the lack of a straight line access had a big impact on this occurrence. So cyclic fatigue resistance depends on the angle and radius of the canal curvature and the size of the instrument at the beginning of the canal curvature. And cyclic fatigue is one of the ways that endodontic instruments fracture, and in this situation it might have been the explanation. There are other options, of course. We're just kind of going through the possibilities, but we can imagine by looking at the obturation material that was put in the coronal part of the canals that the files had a huge amount of stress when reaching the apical portion. So maybe this was one of the important reasons why we had this kind of accidents. So what are the modern tools in access cavity preparation? After this introduction, where I had the opportunity to explain the classical concepts related to access cavity, I would like to kind of set the bar on what's the most modern trends in access cavity. And we must not forget that the operative microscope, the ultrasonic tips, and the cone beam CT are huge tools that really changed the way we look at teeth in general when related to endodontic treatment, because the cone beam CT, for example, allows us to have a full knowledge of the root canal anatomy before entering the occlusal surface on our access cavity. And that is huge, because we know already if we have to look for 1, 2, or 3 canals. Many times we can see them, but we also have to consider that sometimes the CBCT won't allow us to see everything, 100% of the things we should find. But we'll discuss a little bit about that in just a moment. The operatory microscope, on the other hand, as I told before, is a very important tool, and really it gets us to another new level, and it allows us to make procedures that otherwise would be impossible. I was talking a little bit back in this presentation that the operative microscope or the operatory microscope is not mandatory. Well, we'll see that if we are talking about access cavities as they are being presented nowadays by some clinicians and even studied by some scientific papers, we'll see that the operatory microscope in those cases is really mandatory. So maybe some of you have already realized that we are talking about very constricted, very conservative endodontic accesses. Well, this began by the hands of some very skilled clinicians that started showing cases where they had done very, very small preparations. And of course, we began to see clinical cases that really defied some of the classic basic principles. And it didn't take long until someone came up with a name to these preparations. So you probably have already heard about ninja access. So ninja access is something that was, of course, created on social media forums, and it kind of gives us the idea and sets the bar for these types of access preparations, because they are indeed very, very narrow, and you always imagine a ninja doing something that is very precise, very delicate. And cases like the ones that I'm showing here by Dr. Michael Trudeau, and you see that the endodontic access is minuscule. It's just a small hole, and it allowed to make the endodontic treatment, and at least as we can see in the x-ray, it really seems very nice. So what is the basis for this decision making? Well, we have some articles that kind of discuss the principles, or at least what is believed to be the scientific principles, and I'm putting them between commas because there's not many studies about this specific advantage, but it has some logic to think about these principles. So I'm not discarding them 100%. I'm just saying that this is a beginning, and this is very important to kind of give a first kick on the investigation and on the study of this subject, which these articles that were published a few years ago really set the bar to study and to try to realize if there's a point in these situations. So these ninja accesses, or these conservative accesses, should I say more scientifically, are based on the principle that the distance between the centroid point and the flange areas determine the resistance to bending. So this was imported from architecture and engineering, and it kind of makes some sense when we translate it to dentistry. But of course, we must not forget that on the pyramid of scientific evidence, these articles are not very high. They are not very close to the tip. They are much more on the lower bar, which doesn't kind of remove the interest and the importance of such articles, because many times the science advances with articles like this that just point out a finger to something that feels logical and feels important, and then science goes a little bit behind because, of course, scientific articles and scientific investigation, it's much more difficult to produce. But nowadays we have already some scientific evidence that I would like to present you and share with you. So you can see plenty of cases that are presented and that base their philosophy on some principles that I'm going to explain a little bit later. So, of course, this is the contrary to what was also called in the internet forums as the bombed out access or the sumo access. But of course, the sumo access is nothing that we want to do. We all know that the destruction, the massive destruction of sound tooth structure is absolutely to avoid. So in this discussion between a classical endodontic access cavity and the ninja access, we are not comparing the sumo access versus the ninja access. We are talking about a more conservative, but still following the sound principles that I talked in the beginning of this presentation. So it should be more reasonable to talk about, I should say, maybe the samurai access. So we should talk, if we are still following with this kind of nominae, the samurai access versus the ninja access. So this is what we are going to discuss a little bit more, this conservative or contracted access cavities versus the more traditional, the more classic access cavities. And if you would like to call them samurai and ninja, go ahead. Of course, this has nothing to do with science. It's just more like a joke that initiated in the forums and I'm trying to bring to my presentation. Okay, so what is the principles that support or that are the basis for the ninja access? Well, we know that this ninja access proposes an extra conservative approach where the microscope is mandatory, as I said before, the CBCT is highly recommended, and of course, like Dr. Buchanan says here, the computer tomography imaging today is essential when cutting minimalistic access cavities, as canals are counted and located in computer space, obviating the need to cut larger access preparations to view everything directly. Okay, so the CT imaging is really important. But an in vitro study that compared 4 diagnostic methods to identify accessory mesial canals in lower first molars realized that 27% were identified by the CBCT and 30% were identified by the operatory microscope. So indeed, the operatory microscope and our vision gives us better results than the CBCT. If we have both, of course, we are much better off. But it's important to also highlight that in this specific study that I'm showing, the type of access cavity that was realized was a conventional access, so more like a samurai access, if we should say so. So classical, a conventional access, and not a ninja access. If it was a ninja access, maybe the results were not as good as we have here. I don't know. We don't have any scientific study that studies specifically the same subject. Well, we also had this article that's this in vitro study compared the efficacy of clinical and radiological methods in locating second mesial buccal canals, the MB2, in maxillary first molars. And they realized that CBCT revealed the presence of 54% of M between the canals, and the operatory microscope revealed the presence of 58% of MB2s with a conventional access. So it seems that according to these two studies, operatory microscope is still a better tool to locate and to investigate the presence of MB2. But I'm not saying that the CBCT is not important. It is very important, and if we have access and the possibility to have CBCT images prior to the treatment, we are much better off because we'll have a huge amount of information, not just counting the canals, but a comprehension, a total comprehension of the root canal anatomy, which is really very important. So the conclusion that this article achieved is that there is no significant statistical difference in the ability of CBCT to detect MB2 canals when compared with clinical assessment with an operating microscope. So it is very important to not just follow the images that we have in our CBCT, but also keep in mind that the operatory microscope in these specific cases is really very, very important, or magnification in general. So, the amount of dental restorations appear to have a negative impact on CBCT image quality. We all know that if we have metal restorations like amalgams, they hinder many things in the CBCT, and they have a negative impact on the quality, and they kind of diminishes the possibility of observing and of analyzing small details on the images. So this gets us to what I have already said before from this study from Paul Abbott, that without the complete removal of restorations, there was less than 60% chance to detect caries, fractures, and marginal breakdown. It's never enough to highlight this specific point, because nowadays maybe we get a little bit excited with all these modern tools, and we forget those very classic but super important principles like this one. We should never forget that if we don't do the complete removal, we might just lose the possibility of seeing and finding some negative impact situations that otherwise would be still there, and might even in the worst scenario take our endodontic case to a failure. So, considering this, and considering that almost all the teeth that we approach endodontically have caries, huge restorations many times, and as I've said before, being such an important step to remove all the restorations, does the Ninja access make sense only on unrestored or minimally restored teeth? Well, I think that's a fact, because if we have huge restorations and we know we should remove them in order to make a correct assessment of what's beneath them, then this very constricted or this very conservative access should be considered only on unrestored or minimally restored teeth. So let's talk about the cuspal stiffness, and I'm going to talk a little bit about this article that was published a few years ago, and it's considered almost a classical article where they compared different types of cavities and the impact that it had in the cuspal stiffness. And they realized that MOD cavity preparation, which is probably one of the biggest preparations that we make with the highest reduction in dentin and enamel, reduced the relative cuspal stiffness by 63%, which is huge. But then they realized the MO and the OD cavity preparation reduced the relative cusp stiffness by 46%, which is a little bit less. The occlusal cavity preparation, on the other hand, reduced the relative cuspal stiffness by 20%, which is still important. But what is more important in the study that these investigators did is that the endodontic procedures reduced the relative cuspal stiffness by 5%. So what we see here is that the endodontic part of the access is what had the least impact on the stiffness of the cusps, which is important. I'm not saying that it doesn't impact, it really does impact, but as we can see, is a very small percentage when compared to everything else. And on this other article where the cuspal deflection was studied, they increasingly did extensive MO or MOD cavities. So they tested increasingly extensive MO or MOD cavities, followed by an access preparation to try to see what is the relation of each of the steps on the cuspal deflection. And they realized that the cuspal deflection increased with increasing cavity size, with the greatest deflection after access preparation. So this highlights the importance of cuspal coverage to minimize marginal leakage and cuspal fracture. So this in posterior teeth is even nowadays very important, and we should always consider. So going back to the Ninja access, we know that the round burrs, according to the clinicians that propose this kind of accesses, round burrs are to be avoided because many times the burrs kind of gauge the canal, as I'll show in the next slide. So ultrasonic tips, endosonore files, or the EndoGuide burrs from SS White were developed specifically for these very conservative accesses, which are very interesting burrs, but they do have to have a very skilled clinician and all the modern tools behind us so that we can follow all the path without any deviations and without any errors. So what I was talking about the round burrs is that many times when we use the round burrs to try to remove those small areas that still remain of the roof, we kind of end up with something like this. So we are gauging the canal walls, and it's kind of like we are passing a scoop over the walls and ending up with a wall that is nothing but smooth, which is something that we really want to achieve. So the complete unroof of the pulp chamber is unnecessary as long as the straight line access exists. And this is something that is really very different from the classical mandatory actions. As we said before, the unroof of the pulp chamber, the complete unroof of the pulp chamber is important and is something that is taught as one of the very important steps of the access cavity preparation. But if we're talking about these very conservative or very constricted accesses, the complete unroof of the pulp chamber is considered unnecessary, as long as we have straight line access to the canals. So ultrasonic tips are used for the removal of pulp horns tissue. In this case, because we do end up with areas of the roof that were not completely removed, we end up with pulp horns and pulp horn tissue in that area that should of course be removed. But if it is not removed by our burrs during the access cavity, when we have to use something to remove and to clean those areas. So I would like to show you this case that I did a few years ago, and I did a Ninja access cavity on an anterior, on a central incisor, and this video or this clinical case was made exactly to assess and evaluate the difficulties that we have during these procedures. So if you'd like to see the complete case, you can just go to YouTube and type Ninja access. It will be most probably the first case to appear, and this is the case, the completed case. And if you watch the entire video, you'll see that there are many steps of the procedure where I had really big difficulties to perform. So here it is. If you go to YouTube and you type Ninja access, it's going to probably to be the first one to appear in the list. And if you watch this video, please don't forget and subscribe my YouTube channel. Okay, so the basic concept and the basic philosophy of Ninja access is the minimal dentin destruction for maximum tooth structure. This is the basis for going towards a very conservative or an extra conservative access like these ones. Okay, so what does the scientific literature says to us about this specific topic? Well, we know that almost scientific articles concerning resistance to root canal treated teeth relates to different preparation for crown rehabilitation or different restoration materials. So there's not much in the literature on this specific subject of a very conservative endodontic access cavity. Almost all scientific articles correlate dentin thickness and fracture resistance, relating it to the ferrule effect. So what is the real impact of dentin reduction during access preparation on tooth resistance? So the first article that appeared was this article by Rajesh Krishan, Frank Paquet, Shimon Friedman, Anil Kishan, all very renowned investigators and endodontists that decided to evaluate and to assess the impact of a conservative endodontic access, should we call a ninja access, on root canal instrumentation efficacy and resistance to fracture, and they assessed it in incisors, premolars, and molars. So this first article was very important to see and to realize, try to understand the real impact and the real advantages that this kind of performance or this kind of line of clinical approach would have in our treatments. So the conclusion that they reach is that the conservative endodontic cavity conserved dentin in 3 types of teeth and benefited the increase of resistance to fracture in molars and premolars. Well, this conclusion seems really important, and when we look at it, we are drawn to realize that in fact these conservative accesses are very important. So if we look at the loaded fracture, if we analyze a little bit deeper the investigation that was performed, we realize that there is in fact a great deal of a difference between the conservative endodontic access cavity in premolars and molars. If we compare the conservative and the traditional endodontic cavity, there's a big difference, specifically in molars. But nevertheless, we should always remember that the force that we exert when we are using our teeth to masticate does not exceed 600 newtons during the normal physiological functioning of posterior teeth. So if we think about the newtons that we have in the molars in the conservative endodontic access, which is 1,587 newtons, it is equivalent to 161 kilograms, which is a huge amount of force, much higher than the force that is normally exerted during the normal physiological function of posterior teeth. So at the first impression, this might look that in fact there is a great impact on resistance of teeth when comparing conservative and traditional endodontic access cavities, but in fact what we see is that there is a difference, no doubt about it, but still the conservative endodontic cavity leaves a structure that can most of the times stand the forces that are exerted during the normal function of posterior teeth. So that's an important aspect. So this leads us to the question, why? Why should we do a conservative endodontic access? And at what cost should we do the conservative endodontic access? Well, if we go back to the study that I was presenting before, they also evaluated the instrumentation efficacy, not only the resistance to fracture. And on the instrumentation efficacy, if we look at the bottom of this list of values, we'll see that the total canal that was untouched, or the percentage of canal that was untouched with both types of endodontic access cavities, we'll see that there's a very big difference between the percentage of canal walls untouched with conservative endodontic access and the traditional endodontic access. And this might have an impact on the success of the endodontic treatment. There's no investigation and there's no scientific proof that it has an impact on the success of the treatment, but of course we know that by leaving untouched wall, probably it will have also a negative impact on the disinfection procedures, and it might be kind of an impediment to the successful fulfillment of all the correct procedures during the endodontic treatment. So one other stuff that I would like to point out in this study is that this study studied the untouched parts of the root canals, as we seen in the previous graphic or in the previous table. But actually, what about the pulp chamber, the pulp chamber was not evaluated in this study, and as we can see in this micro CT images, where we see in red all the areas that were touched by endodontic instruments or burrs, and in green all the untouched areas of the root canal system, we see that we have massive areas in the pulp chamber. Of course, you might think, okay, but the disinfection procedures will take care of that, and if we use those ultrasonic tips as I showed before, maybe, but there's not a proven study that says that by leaving all these untouched areas will have or not an impact on the success of our treatment. So it's something that we should always consider. So there's a second study that was published by Gianluca Platino, my dear friend Gianluca and Nicola Grande, that a few years later published an article that kind of uses the same methodology to evaluate and to assess the different access cavity preparations. And in this case, they went a little bit further, and they evaluated the conservative endodontic cavity access and the ninja endodontic cavity access, which is even smaller than the conservative endodontic access. So this is a very, very recent article, as you can see here. It's from 2017, June of this year. And what they realized and what they did was, in fact, to compare three types of endodontic access cavity. A is a traditional one, B is a conservative, and C is a ninja endodontic access cavity. So what are the results that they achieved? What they compared was the coronal dentin and enamel volume removed, or the percentage of total crown volume that was removed during these accesses. And as we can see in the table, there's really a very considerable difference between the traditional, the conservative, and the ninja endodontic access. If we compare the traditional and the ninja endodontic access, then the difference is huge on the amount of volume that was removed. So in fact, there seems to be some kind of an importance in the reduction. But is that reduction important when assessing the fracture strength to these endodontically treated teeth with these different access cavity designs? Let's see the results. So what we see is that the load at fracture, which is the maximum force exerted over the crown for them to fracture, and we see that there's in fact a difference. We can realize that there's a difference mainly between the traditional endodontic access cavity and the conservative and ninja endodontic access cavity. But between the cavity, the conservative and the ninja endodontic access, as you can realize, the difference are very, very slight, not statistically significant at all. So it seems that we have something here, but this study pointed out that probably the ninja endodontic access or those super constricted accesses may not be very advantageous when compared with a more conservative endodontic cavity access, but maybe the conservative endodontic access cavity could be a little bit better than the traditional endodontic cavity. Okay, so the conclusion that they reach is that further clinical studies are necessary to determine the efficacy of instrumentation, difficulties during endodontic procedures, and long-term prognosis of endodontically treated maxillary and mandibular molars and premolars with conservative endodontic cavities and ninja endodontic cavities. So these are all things that we should study on the months and on the years to come, so that we can draw a more solid conclusion on what we should choose regarding this aspect. So another article that is very important was published also very recently, and it studies the fracture resistance of endodontically treated mandibular first molars with conservative access cavity and different restorative techniques, which is kind of something different from what we saw before, because before they studied the type of or the design of the endodontic cavity access cavity and the relation between that access cavity to the fracture of the tooth. And this article goes a little bit further by doing an endodontic conservative access and then different restorative techniques, and to see what is the impact of those variations. So here we see an example of the endodontic access cavity, and as we can see, it's more like a conservative endodontic access cavity, not such a ninja endodontic access cavity, which would be much smaller than what we see here in this picture. And the conclusions that they achieved were that regarding the type of restoration, and they compared amalgam, composite, inlay, onlay, and crown, and we see that the maximum load until fracture is very different from one to another. So what we see here is that the one that had the better result was composite, which it's something a little bit strange by looking at the beginning, because maybe you thought, but didn't we talk about the importance of doing a cuspal coverage? Wouldn't the crown probably be better off as a result in this study? And also the amalgam, we also know that the amalgam, maybe it's not very indicated in some cases, but still it had very good results in this study. So let's evaluate another thing that they studied also in this article. They not only studied the maximum load until fracture, but they also studied the type of fracture that occurred on the tooth when it happened. And we know, of course, that we can have several types of fractures in our teeth, because of course we can have a small fracture that is completely repairable, until a catastrophic fracture that really leaves no option than the extraction of the tooth. So it is very important to study what is the kind of fracture that occurs in each of these cases. And by looking at this graphic, things completely change. As you can see here, the amalgam had a very, very poor result, but the composite was even worse regarding the unfavorable type of fracture. So in this case, if we compare the one that did had the highest loaded fracture along with the most favorable fracture when it occurs, then we go to the right of the graphic towards the onlay and towards the crown, which had an even better behavior in this study. So when we think about retaining tooth structure, and when doing a constricted endodontic access cavity, we must always keep in mind that by doing so, and for example this very big x-ray that I show you here, that where you can see that the endodontic access cavity was all made by the mesial, not touching the distal restoration, that in my opinion should be removed, because as we saw before, it might hinder some marginal breakdown. We even see in the x-ray that probably we have some leakage in that area, but nevertheless, if we look at the canals, we realize that this is a very poorly done endodontic treatment. And of course, doing such a constricted endodontic access cavity was not helpful at all. So is this a ninja access cavity? Of course not. So this is the tooth retreated afterwards, and in this case we had to remove all the restoration, we corrected all the things that had to be corrected, and we did restoration with a full cuspal coverage in order to have the most resistance to fracture, along with a very well performed endodontic treatment. So I'm almost finishing this presentation, but wouldn't it be good if we had some kind of a study that was on the tip of the evidence pyramid, that could show us like a systematic review or a meta-analysis that could show us, and comparing all the articles and what is on what has the scientific literature published so far, so that we kind of have some guidelines on selecting the most correct approach in these situations. Well, the good news is that we do have an article like that. It was published this November by my fellow Brazilian colleagues from the team of my dear friend Gustavo de Deus, And they published this systematic review of the in vitro studies that were published so far. So they just kind of gathered all the studies that were published so far, and they analyzed it, and they tried to draw a conclusion from what the science at this point says, and from that we might kind of set ourselves some guidelines on our clinical approach. And the conclusion is really very, very important. So this systematic review demonstrated that there is no significant scientific evidence that supports the use of conservative endodontic cavities over traditional endodontic cavities for the increase of fracture resistance in human teeth. Of course, they discussed that it is important to pass to another level, to a different level of investigation, which would be the clinical trials. But on what we have at the moment, what has been published scientifically, this is the conclusion that we might draw from that. So when should we do a ninja access? So I'm going to end my presentation showing you a clinical case where I think that maybe in this specific case, or in these specific situations, endodontic ninja accesses might be the correct approach. So this was a case of a colleague that had done an endodontic treatment and then a full crown, but during probably we never realized exactly what happened during the treatment, because the endodontic treatment was performed by a very dear colleague of mine that I know that works really, really well. So he would never leave that distal buccal canal completely empty, but in fact we think that probably during the prosthodontic procedures, maybe there was the intention of placing a post in that root. Maybe the root canal filling was removed, and probably it was removed excessively, and at the end the crown was done, and that specific problem was not addressed. So this is the current situation. The colleague was called me and asked me what could I do without touching the crown, because the crown, as we can see in the x-ray, is very, very well performed, very well adapted. It was aesthetically pleasant. So our intention was to try to correct that specific problem without disassembling all the crown and without a massive destruction that we would have to do. So in this case, I did do a ninja endodontic access cavity. I had to use very small burrs. In the case I used the Mueller burrs. I also used ultrasonic tips, very thin tips. And so I was able to approach the root canal. I also had the CBCT imaging, which was also very important to do the specific measures in the images that could help me to locate and to go very straightforward in the very correct direction of the root canal. So here you see a very traditional photograph that most colleagues that do a ninja endodontic access always do, and to show the colleagues, to show how small the access cavity is. I'm comparing it to a rubber stop, and the canal at this point is filled with sodium hypochlorite. So this is a photograph that was done under the microscope during the endodontic procedure. And now we see the canal that was completely filled and packed, and this is the final x-ray where we see the problem solved. So at this point you might thinking, but shouldn't we have done the full retreatment? Shouldn't we have also addressed and approached the other canals? Well, maybe so, but there's a novel approach that is being that was published a few years ago by Dr. Nodera, where he proposes a novel approach in this kind of cases, which would be a selective root canal retreatment in this case. And as he says, in this manner, retreatment could be limited to a single root or root clearly showing periapical pathosis, while leaving the roots with no visible or perceived pathosis untouched. Of course, this is an approach that has to be very well calculated. We have to have a solid confidence on the treatment that was performed prior, which I had in this case, because I know the endodontist who performed it, so I had no doubt that the endodontic treatment was performed with the highest level of quality. So this was a very, very specific case, and in this case I think that it could be a reasonable approach to correct this situation. So final remarks on my presentation. Always remember that magnification leads to more conservative preparations. CBCT is very important but cannot replace vision, specifically vision with magnification. Underextension may cause missing anatomy, missing cracks, instrument separation, incomplete cleaning and shaping. But always the aim of our endodontic accesses is to achieve minimal loss of structural integrity of the tooth. And of course, restorative procedures have to accommodate the elimination of the disease and not the other way around. Okay? So on this final discussion about ninja access and samurai access, I think both terms are not that correct. Maybe I should propose a different term. So maybe we should all talk about something like a Zen access. And what is a Zen access? Well, I think it's the most elegant access preparation combining convenience form with conservation of tooth structure, because at the end of the day, it's all about balance in endo as in life. So I leave you with this message. I hope you enjoy this presentation. I hope you have some takeaway from this, all the sharing of this of this knowledge and of these scientific publications. That it was really fun for me to go and analyze with the highest detail that I could. And I would like to leave you with this quote from George Bernard Shaw, where he says that if you have an apple and I have an apple and we exchange these apples, then you will still have each one apple. But if I have an idea and you have an idea and we exchange these ideas, then each of us will have two ideas. And well, I think we have to agree that sharing is all about this Congress. And I would like to leave you with this quote: sharing is everything that's beneath the mission of this online Congress. And I hope you enjoy this presentation, and I hope you stick to the rest of the week, because we still have beautiful lectures that you will probably and I wouldn't say probably, I would say certainly you will enjoy them very much. Thank you very much, and we'll see you soon. Don't forget to use the comments below and to give me a feedback on this presentation. If you have any questions, go ahead. I don't promise to answer them quite right away, because as you probably imagine, I'm full of work during this week, but I'll do it as soon as I can. Okay, thank you very much for your attention, and keep doing endo and keep striving to do better dentistry in your life. Thank you.